We'll talk about the pupil snap sign. So what's a pupil snap sign? The pupil snap sign that sometimes happen when you have a constricted pupil, or even previous uveitis, pseudoexfoliation, and sometimes extensive use of myotics, or even in some diabetics. That means you can find this just a sudden pupil constricts and snapping. Just so what will you do in such case? If you see it in a slow motion here, what happened? It's narrow pupils, and I'm trying to push the iris, and then I find this sign. That what does sign means? So I continue and take the decision that I'm afraid that something happened. I can't use even a scaffold technique, or I don't know, I don't understand what happened. So I find that the lens is going to dislocate and falling down. That's why I just take the decision to widen the wound and take it out to prevent this disaster. So it can happen sometimes even with a wide pupil. Like in this case, that was a traumatic cataract. We didn't recognize that. Then I find that I take the edge of the bag in my phaco tip. That happens. Then when we review the case in a flashback, that find that was when I was doing the rexes, that I find that there is a corrugation in the anterior capsule, as we see. That means that we still have some sort of subluxation. In this case, you don't find that the vitreous is coming in the anterior chamber, but you just have an iatrogenic iridodialysis. That means that the pupil snap with the vitreous coming in your phaco handpiece. Now we can see it again in this case here. It's what a little bit hard case. Try not to move your case. You can use more phaco power, or you can use a little bit slow motion, or you can use don't go deep in one time. You have to take steps and steps and steps. Then I didn't recognize what happened here. Now I'm trying to divide, still needs more and more getting deep. I didn't recognize that I have this snapping even, but everything is going okay. Then I didn't recognize that everything is going okay. It seems for me everything is okay. Then it comes the time of the snapping again. But I find that everything is okay. So trying to take this, still attached. I need more and more grooves. Then I'm trying to push here and here, and then still snapping. I didn't recognize. Then I go out and to see if there is the pupil is getting constricted, to be sure if there is a vitreous in the anterior chamber or not. No, the pupil constricts and the anterior chamber is still shallow. That means I have no vitreous in the anterior chamber. So that's why I continued the case in such way. Then if we see it in a slow motion here, what's happening here is the snapping. Now we can see it in a slow motion, constricting of the abrupt movement of the iris, like here, you can see it. That means that you have an heterogenic cut of the zonules, and you can face that this lens is getting more. The problem here is you didn't recognize what happened. So even in such case, it can happen for me. I can use the scaffold technique. I just put this case as a demo for my work that we can use it, but we couldn't do that. So what happened in the case, likely when I found that I have to take the decision now, here now, I recognize in this step that I have a problem here. So now at this time only I recognize that I have a vitreous. I have some problem here. Now I recognize that I have a vitreous. So I couldn't do the scaffold technique as I do in the last case. I have to widen the wound and to save the case, and trying not to open. You have to open the wound as much as you can, so you can explant even. And still I have a bag. I found that I still have a bag, and that's why I put an IOL 6.5 piece and put it inside in the bag to work as a CTR. And this is the final when I do my vitrectomy, and everything was okay. This is the vitreous band. I remove it, and this is the final, the end of the case. Thank you very much.
Thank you, Dr. Ahmed. It was a challenging cases. Thank you very much. Now we will move to the questions. Anyone have any comment or questions? So, yeah. So you are asking Dr. Ashraf.
Yes, what's the question? I didn't. Yeah. Yeah.
So, do you get the lens thickness with any of the methods?
Yes, definitely. Any biometry formula, it has a length thickness. And this is very important. This is a part of the data you are going to put. Even in the new ESRS calculation formulas, the new formulas with the AI, they ask you for the lens thickness. The lens thickness and the AC depth. Now it's a crucial in proper calculation of the IOL.
So, in which cases do you don't get lens thickness? I have seen some cases when you do the A scan, you're not getting the LT with Master 700. Which cases do you get? So, normal refractive patients, but I'm not getting the lens thickness either by contact biometry nor by IL Master.
And even the IOLASA 700s, you cannot get the lens thickness?
It's not coming in the machine for few of my patients. I don't know. I want to know the reason for that.
Sometimes if there is a corneal opacity or
No. Absolutely clear. Myopic patient.
the IOL Master 700 or
Yes.
even
Yes, both.
I don't have a clue.
Anybody in the audience or anybody in the panel have the answer for this? No, it's not about the formula I'm asking of. For the refractive patients, young people, 18 to 22, some few of my patients' lens thickness is not coming. Even with master, not with biometric, nor with contact, neither. Yes.
I think that this is a problem of the machine because you should have it.
Yeah.
Otherwise, we will change the machine or we'll go to another center to measure the lens thickness. But always we have it.
Yeah.
Yes, my dear.
Good afternoon. I'd like to ask Dr. Isam, and I'm very happy to see this challenge and this combination of in vitro and cataract operation. How much the patient gained vision? I hope wonderful, same as his operation. Can you tell Dr. Isam?
Thanks a lot, dear doctor. She's a high myopic patient, so she has a little bit amblyopic, so it's 6-12. Best corrected with a small cylinder. I think it's due to the lens. Thank you.
So my comment now to Isam, when we have subluxation of the lens and whether we will use definitely the iris retractor, it's because the pupil is small. But for the capsular retractor or CTS, that's my comment here. I prefer CTS. Why? Because first, the long arm of the CTS, and you can use two sides if you have total subluxation. So when you have a total subluxation, especially in the traumatic cases, I have one doctor that he has total bench, so mydriatic pupil and total subluxation. So what I did is that I turn back, the pupil is dilated. So I first did my capsulotomy very carefully, holding sometimes the capsule, and then I introduced the CTS. And from the eye of the CTS, I put the retractor. So you have two CTS on the side, and the retractors will tracting them. Now the tension of the arm of the CTS will be broad, so you will not have a trauma that might be the Descemet's membrane from the huge size of the capsular tissue. Anyway, this is not because I saw the movie.
Yes. Even Dr. Hisham, I feel I would go for a manual small incision cataract surgery instead of going with a phaco in such a rock hard cataract. Manual small incision cataract surgery and event occurs, I would go for an iris fixated lens.
Yes. Yeah, but we are talking about preserving the capsule.
Yes.
So preserving the capsule with the CTS, then the capsular tension I prefer it.
Yes.
And-
Regarding for your comment, dear professors, if it is traumatic, usually we have weak zonules on one side and the others are okay. So I need one CTS would be enough. In such cases where you have an extensive 360 zonular weakness, you need to have a best control from all directions.
That's what I'm saying. Two
I need
CTS.
I need two CTS.
CTS you
Yes,
have
this will
here.
take longer time actually. So I'm trying to be quicker. Regarding the second one is the small incision cataract surgery with this dislocated and this patient who have high myopia and have other eye lost due to retinal detachment. So I'm having a high risk of retinal detachment. If I do a small incision, I will do an intracapsular cataract extraction with massive vitreous prolapse during the surgery. This will increase significantly the risk of retinal detachment. This is not what I want. So I want to be as preservative as possible. I want to be not inviting vitreous to my anterior chamber while doing the cataract surgery. And if I am forced to go to the vitreous cavity, I will go with the cutter and will shave it with my own cutter while not prolapsing it and causing any traction on.
Yeah.
Thank you.
Any other questions?
So I think that we need to close,
Close.
because we are preparing for closing ceremony. So we will open all the halls for the closing ceremony. So you will wait. Yeah, we will wait. Yeah.
We want to all celebrate together. So the closing ceremony, we are going to open the two halls. It's a scheduled ceremony with a lot of things and also a lot of surprises and very, very, very nice prizes for the winners. You are going to see. We want to make everyone happy, really.
We'll take a group photograph with all the speakers. Thank you.